guys, we're going to do the new Lowland Rescue ST course. This replaces all of our previous medical training at this level. So we're now going to do the National Triple C course, which is the Clinical Competencies course. Hopefully it will give you a bit more confidence out on the road to be able to manage and deal with MISPers as and when you find them. I'm trying really hard that we move away from being dependent on LRFRs before ST take action that can save lives. So we've recorded this so that every time we need to re-go over this with new people or people who couldn't be on the initial sessions can get exactly the same learning. The LRFRs have come along and done lots of filming with me so that we can show you as many skills as possible with different people so that you have a different appreciation rather than just listening to me chat all night. Some of the biggest changes that we've got are that you now have check cards. So each of you has been individually issued one of these and they will be ready for you to collect from HQ. You just need to organise yourself with Casper. For STs, you'll have the cards on the left-hand side with the green corner. This is your scope of practice that you're expected to be able to deliver. For LRFRs, if you pick up some of their cards, they'll have a red corner, but otherwise they look very similar. ST has a lot of cards that look like they're missing. You quite easily have in an order cards 3, 6 to 19 and look like you're missing some. The ones that you're missing are our LRFR scope of practice. When we look on your cards, some of them look like they have faded out elements. If you look on the left here, you'll see that cards sort of 6, 7, 10, 11 will be missing. They're not an expected treatment plan for ST at this level, but some of the information is still in your cards so that if you're with your LRFR and it is an intense job, you can still help and guide them when they are under pressure. So this is a really good example. They're both card 3. The left side with some of it blurred out is because it is outside of your scope of practice. So for example, under external bleeding in purple here, it says giving Entonox, which is blurred out on the ST's version because you are not authorised to give medical gases, whereas the LFRs are. So on the cards on their right-hand side deck, this is all included. In the LFR bags, in our medical bags, is a large set of red check cards so that on an incident that was quite busy or quite intense, anyone can pick up a spare set without having to rely on individuals to have their cards with them and be able to help together. It will help us work really closely, which would be great. This course is assessed. It is pass-fail on your assessments. It is now a national requirement that you're able to pass the course. Obviously, we'll do lots of coaching. We don't really expect anyone not to pass it. That being said, I don't want to assess everybody lots of times. So we will come to the face-to-face training after all of the theory so that we can minimise contact where it's appropriate that we do that. And then at the end of the course, for the assessment, you'll have an assessment on basic life support. Using the DFib, this is for adults and for children you'll be expected to show this skill for. You have a small quiz on triage and you have a medical and a trauma scenario each that you need to demonstrate your skills. So we're looking for consistent method so that the day you come across something you don't know what you're dealing with, you can still safely deliver care to a patient. That being said, I'm not going to show you every single piece of kit. You don't need to learn everything in their medical kit bag. You just need to know the things that are reasonable for you to lay hands on. Skills do fade quickly if you don't use them. So if you want to join in med training and I put a session up and it says open invite, then by all means join in. The only ones that are limited very clearly say LRFR only. Let's do the team approach. We've been here before. This should be nice and quick. So we'll look at how we approach medical care as a group effort and talk about principles sort of platinum 10 minutes. So we generally go out in quite small teams, team leader, and within that we might have somebody on nav, somebody who's got radio on and not necessarily a first responder, but certainly somebody who's designated to take command of any initial patient or MISPA contact and run the first aid. From there, your team leader sort of becomes your on-scene commander. It's quite useful roles. If your radio operator can stay in that role, sometimes it's quite helpful that they also then become your scribe, so that when control are asking for things like your at-mist report, the person in charge of the radio is ready to go with that information because they've already had it written down in front of them. A first responder is clearly going to do the medical lead, and a navigator, if it's just you guys there, might be forced into a sort of medical assistant role. If there's a bigger team available, then actually you want your navigator to be working out how are you getting out of there, by which route easiest to pass, whether you're walking, carrying, meeting an ambulance, whatever that might be. So you find your MISPA, report it back. The medical person or the assistant do their primary survey, which is something that we're going to go into a lot in these sessions, and then report back to control with a further update about the MISPA's situation. If it's appropriate and the MISPA is not proven to be critically ill on their primary survey, you can move on to a secondary survey, which is a bit more detailed, includes packaging and your sort of evacuation plan. So there's lots of things to be considering when we're doing this. There's a bit of shelter going on for the MISPA here. They've insulated him from the ground. That looks good. The only difficulty of this kind of close proximity care is none of the rest of the team can see what's going on with the MISPA. They can't tell what conversations, injuries might be going on. And currently in COVID times, you're not going to want to be so close to anyone. That being said, they look like they're working really well together. They're clearly worried about a scoop. They've got head blocks in play here. This is going to be an extrication. It's quite a difficult location. The guy standing up is clearly trying to communicate with somebody. I'd say lose the kit bags, quite off balance here, especially if you're going to carry. Carrying out takes a lot of effort. But otherwise, it's not a bad picture of team approach to casualty care. And you think about kit dumps, where's the med kit going? Can we reach it? I think one of the things we trip ourselves up with is personal kit bags. They need to be out of the way, and everybody helps each other out to return those to the control point should you have to leave your kit bag behind. Think about putting extra layers on. You're going to get quite chilly quite quickly if you're staying in one place. Remember that if you're cold, so is your patient, and everyone is cold who's lying on the ground. A bit of scene control. Everybody always wants to help, but sometimes actually limiting who is right on top of you is actually more useful. It becomes less overwhelming. So you might want to think about, for a team leader, is there an RV point for additional teams or resources that are coming in where you can hold them off until you get the people or specialisms that you're really looking for? Whilst it might be really interesting for everyone to see what's going on, you have to remember a bit of dignity for the MISPA. Generally, if there's nothing critical going on, then get gone within 10 minutes. If we try this in action, the last one I timed, I think our incidents took 43 minutes for decision making to actually have feet in the air and leaving. So unless there's something really compelling that means you have to stay and provide treatment and there's no way that you can extricate, for example, cardiac arrest, no way you're carrying that out, you can't deliver that care, then everything else, try and get everything packaged on the way. Reasons to be staying on scene, we don't all walk around with medical bags and stretchers, so just waiting for resources to arrive, of course, is absolutely fine. Clinical care or access issues that need a bit of help, they're all reasonable things to be staying, but try and think about the fact that the patient does not want to be where they are. They either want to be gone, warm, or on the way to hospital. So within our assessment of this course, this is a team approach course. So whilst individually you will be quite required to lead a situation and demonstrate your skills, there's no sort of one-to-one grilling. For the other team members, when you're assisting during your assessment day, that's sort of competent but lacking initiative would be really valued. So if you're asked to bandage something, then by all means do the best job that you could do, but you can't suggest it to the person under assessment. So we need to go over the inevitable bit of safety dynamic risk assessment. And for this, we have to now include some sort of COVID adaptations to this. But let's start with the things that you already know about. We'll do it briefly. Dynamic risk assessment, a bit of specific risks associated with medical care and some PPE. So we know medical care brings its own specific risks. This is safety of ourselves and our team. We're looking at safety of the scene as of itself and safety of any patients. And that's for all sorts of things, their current injury, but also making sure that the skills are up to date so that you are not a risk factor to any patients. So you approach patient, dynamic risk assessment, any dangers going on, talk to control. Generally, we're dealing with a single casualty incident, in which case you're going to conduct your primary survey, which we'll go into in more detail in a moment, and then report back again to control with a detailed approach. This way you're avoiding the sort of calls that come back in asking for an up-to-date app missed. So your dynamic risks, we're looking at weather, temperature, is it raining, what's the light like? They will make things more tricky. The patient themselves can absolutely be a risk to you depending on what's going on. For example, an agitated head injury, quite difficult patient interaction. And bystanders, particularly when you're limited in what you can do for this patient, that's sort of why aren't you doing anything? It's time to bring out your charisma. Managing medical risks. We do not do mouth-to-mouth ventilation, and we didn't do this before COVID. You all have pocket masks. However, with COVID, all resuscitation currently means that we are not doing any rescue breaths. You don't have the PPE or the equipment to manage that personal risk. Prior to COVID, mouth-to-mouth sort of pocket mask ventilation, is encouraged but a choice. But at the current time with COVID, do not do rescue breaths. Bodily fluids have always posed a risk. This is anything, bloods, vomits, all sorts of nasties, particularly on or around your face from somebody else. Contaminants entering the human body, things that land on your mouth is an obvious one, but inhaled things that get in your eyes, just be cautious with what's going on, especially when you're dealing with an airway. It's polite to everyone to say, oh, I'm just doing something with the airway. Everybody watch your eyes in case there were some vomit or some splatter. Remember that broken bones are sharp, so just watch out where you're putting your hands and remember to wear your gloves. We try and roll our sleeves out the way, mainly because below the forearm is how we operate in medicine to keep contaminants away from the patient, especially when we talk about open wounds. Eye protection where there's a risk of splashing, so the eye protection that you are given in lowland rescue for search anyway is absolutely fine to be wearing here. Controlling of bleeding when it gets everywhere, really gets everywhere, which is why I say try and pop personal kit well out of the way. And currently respiratory protection. Everybody in our team is required to wear a mask always, and where it's appropriate to put one on a casualty, especially a conscious casualty, we give them a mask, and we are carrying the PPE in our vehicles to do that. Let's talk about legalities in litigation, or are you going to be blamed for things? You don't have the Good Samaritan here. We are deliberately training to go out and provide potential care to people. This is not you coming across something in your own life. So we'll talk a bit about the importance of writing things down. Now, the key thing here is negligence, where you owe somebody a duty of care and you breach that duty for which they were injured during that breach. Actually, it's more closed than you might think it is. Your duty of care is to undertake an assessment relevant to your scope of practice, provide safe and effective care within that scope of practice. You are judged by somebody of your own skill set. What would they have done about it? You wouldn't be held to account of another professional or paramedic. You would be judged to your own level about whether your care was appropriate. Now, some of this is appropriate and necessary. So just because you haven't done a skill before doesn't mean that the next MISPA you come across, you give it a go whether they need it or not. So make sure we're only doing what's necessary. So you're quite safe if we follow our training. Would any other first responder, not just LRFR here, I mean STs as well on this new course, with broadly the same training and experience have done the same or similar? Or if Lou stood over your shoulder watching you, would we both be happy with what you're doing? So let's take a case study. It's 3:30 in the morning, and your team have located the 81-year-old gentleman with dementia that you've been searching for since 10 o'clock the previous night. He's a bit cold, otherwise, he seems absolutely fine. You hand him over into the care of the police and pop the details of your find in your notebook. At 3:45, this gentleman, whilst in the police car, suffers a stroke. An ambulance is called, he's taken to hospital, however, unfortunately, he dies that morning. The gentleman's family are understandably upset but grateful for you and your team and the police because you did everything that you could. So, an inquest into the gentleman's death is convened, standard practice following death in custody or care of police. Your team are called to appear before the coroner. It's not going to be 11 weeks after the incident, much longer than that. But the coroner is not impressed that you've recorded the date and time of the find, but no clinical information about the patient. If it isn't written down, it hasn't happened. So for every find, you are all required to undertake an assessment of a MISPA and to write down what you found. Initially, this could be on your check cards or in a notebook, but preferably this must be translated onto a patient report form. There's nothing about the report forms that means they have to be done by the LRFRs. Any one of you is capable of completing these. If there's nothing to find and no treatment was required, you still need to write one. We just write patient not required, treatment not required, or patient declined assessment. That's absolutely fine. There are things you can still look and listen for and make an account for, even if there's nothing wrong. If there is something to find, we can then hand this over to the next tier of care. So on your check cards, there is the very initial patient assessment card here, which is just 2 pages in, which does a really quick helpful thing about whether you're dealing with a non-time critical patient or a time critical patient that needs a lot of care, and it's structured. Now this essentially is your assessment. Follow the patient assessment card. If you can do these things, that is as much as the assessment is, but we're looking for structure, logical assessment. When it comes to recording things, you then have a casualty monitoring card, so you can write down what time it was, whether the airway was good, are they still awake, what's their breathing like, their pulses. You're all capable of doing these things, and you're now required to undertake this level of monitoring. There's a little guide at the bottom to tell you whether it's in normal ranges or if there's an issue going on. There's a nice note page on your check cards right at the back, and there is also an at-missed card and a handover. You'll see here they've actually called it NAT-missed to include the MISPA's name. That's not a problem, it's always very nice, and it will help you communicate with control and to the next level of services as and when they're required. But all of the information captured on here needs translating into a permanent copy onto our paperwork. It is acceptable to take pictures of patients in specific circumstances. So photograph of an injury before intervention. So I have done this at work. If it's a particularly deformed fracture and I need to reduce it, then I'll take a picture before and after. Or where it's necessary to move somebody who is deceased in order to gain access to a live patient. We often would take a picture of their original deceased place within the incident before moving the body and communicate and share that with the police. Be really careful when taking pictures, because in the days of smartphones it will all instantly upload to the cloud, and you need to remove every copy in every location once you have handed over the information. It's not yours to keep forever and ever. Consider that the case study. The gentleman in the car seems absolutely fine with us, and later on after we've left goes on to have a stroke. Did we owe him a duty of care? Yes, absolutely. We went out looking for him. The potential with MISPAs is they are unwell in some way, else they would be missing. But was your duty of care breached? No. You went out, you found this man, you did check him over, you noticed there was nothing wrong, and you correctly handed him over to another agency to continue his care or well-being with the police. And the fact that he had a stroke was not caused as a consequence of breached duty. You haven't caused him to have a stroke by your treatment. However, you haven't recorded these things. This is what the issue is. All you would have needed to do is write down that the point of find and handover of care, the MISPA was fit and well, and the time that your care ends is quite useful to document. That's all there is to duty of care. Let's go into handover and reporting then. So we are looking at a structured way to fill in the form, what the forms look like, and in your face-to-face assessment days, there will be a bit about filling in the paperwork following scenarios. Let's look at the check cards first, because right at the back there's a handover page. Now this is AppMist, although again, I said earlier, they're calling it NapMist, so you can put patient name in it, that's fine. But really, this is what we're talking to when we report back to control. Now, your initial find report might be, we found a MISPA, and then you do your primary survey, and then you go back to control and try and use this format here. You might only have very brief details at the time, but roughly the age of the patient. If they're not conscious, then make a rude estimate of, I don't know, patient looks like they're in their 50s. The time of the incident, so the time that it happened, if you are able to work that out. Otherwise, record time of find. The mechanism of injury, how did it happen? It's a real basics here, and we're talking really basic. They were mountain biking and slipped down a slope and hit a tree, I don't know, whatever it is. So how did it happen? How have they become injured or unwell? It might be that you have to summarize it, so it might be that your patient can't tell you. It might be that it's quite a simple incident and you have a patient with a dementia who actually took a tumble and are sat cold and chilly in a hedgerow and they've got a few scratches, in which case you can say mechanism assumed fall with minor injuries, for example. You're assuming, because the patient might not be able to tell you. Any injuries, we also mean any illnesses. So not everything is trauma, some things are medical, by which we mean they might have chest pain, they might be having a heart attack, they might be having a stroke. These are all illnesses, not injuries. So just bullet points is absolutely fine here. Try and determine left or right side is injured. Make sure it is the patient's left-hand side, not your left or right as you're looking at them. Any signs and symptoms that they have, remember, you'd go into your sample here to give you more space to write, but on the AppMist, we're looking for the really critical things of when you first got there, what was the patient like? And on your last assessment, most recently, what were they like? And this gives us a trend to very quickly understand whether the patient is stable, improving, or deteriorating. And any treatment that you have given. This includes all the basics for I opened their airway with a head tilt chin lift and their airway is no longer noisy, or they vomited and I use postural drainage to protect their airway and stop them from choking. All of that, just jot it down. And remember what you then need to translate this onto the real patient report forms, the PRF. So for example, an AppMist really briefly might sound like, this is Kevin, he's a 20-year-old male, so age, who about 45 minutes ago, time, fell approximately 3 meters directly onto his feet following a rock climbing incident. So this is the mechanism, what happened and how did it happen. Illnesses and injuries. He's got fractures to his left tibia and fibia and his femur, so his whole left leg is broken everywhere, and potentially a fractured pelvis, but there are no other major concerns on primary survey. Signs and symptoms. The only symptoms noticed are significant left leg pain, but normal sensation. For your check card, you'd include things like that he was still conscious and what his rest rate and heart rate were. Treatment, we've given him Entonox analgesia, he is immobilized, we're using a traction splint, a pelvic binder, and we're packaged in a vacuum mattress. So when you read it all through quite quickly, this is how an AppMist looks. It's really blunt, there's no opinions. These things are present or I'm concerned about them, is the format that this goes in. This is what our paperwork currently looks like. It's not the best, but it's all right. My biggest pet peeve is on the top right. This is treatment about fluids, oxygen, and medicine. It says medication. And bandages or wound care are not medicine. Please don't write them in those boxes. This is for giving oxygen, or the patient took their own DTN, or they took their own inhaler. Fine, when did they take it and what did it do? Or it's for the LRFRs to record the medicines that they will give. For the rest of you, use the box under primary survey on the left-hand side for findings, or secondary survey for what injuries you found, or on the right-hand side there's a body map where you can draw little labels and say what was wrong and where and what treatment you did about it. But bandages are not medicines. So at the right at the start, this is the top left of the form, which team you are. So you'd be given your team allocation by control right at the start. Who is the lead medic, or if there are multiple medics, they all need to go in the box, please. Location of find or nearest town is fine. Date and time that we arrived on scene with the patient, not date and time that we went looking for them. The patient's name, their date of birth, their address, telephone number, and a next of kin. Please also get the next of kin's phone number if it is possible. There's a little bit of help with your sample here for allergies, medications, past medical history, last eating or drinking. And at the box, it's sort of a combined events between events or what has happened. Same box. Remember, this isn't a story time. This is blunt bullet points of this and then that. Underneath that, you've got a really quick tick box for your primary survey. It's come up a bit funny here, but it's fine. Did they have catastrophic hemorrhage? In which case, did you put local dressings on it, or pressure, or tourniquet, those kind of things? You just tick the box. If it's not applicable, just leave it, and you move down to airway. If you had a C-spine concern, tick the box. Otherwise, is the airway obstructed? Is it loud? Is it snoring? Is it noisy? Was it a choke? Did you manage to clear that? Did you do a jaw thrust? Or if you're combined working with an LRFR, did they choose to use an airway adjunct? Just tick which applies, so you can tick multiple things. Or when you got there, was the airway nice and clear? Move down to breathing. Absent breathing. Assist ventilations is LRFR or above kind of thing. If it's absent breathing, then you're going to assist ventilation because you're going to do CPR potentially, although not in COVID times with rescue breaths. If the breathing is present, you want to know if it's less than 10 or more than 30. Tick the box, that's a problem. Otherwise, if it's between 10 and 30, just tick the other box. We're just looking for rough numbers on the primary survey here to work out if something critical is happening. Move down to circulation. If they haven't got pulses, or they haven't got, just do some CPR, that'd be great. If they have got pulses, tick the box. Sometimes it's useful if you tell us where you found a pulse. So on their wrist, which is a radial pulse, or a central pulse on their neck. It just gives us, if you couldn't find a radial but you can find a central, that tells me a lot of information. Disability, we're looking at, are they alert or was it voice pain unresponsive? Just tick the box that applies. Remember, this is when you first found the patient. Anything that you reassess, you write elsewhere on the paperwork. And then it helps you do your secondary survey. Now, the label for secondary survey is down at the bottom, but it actually includes the right-hand side of the page here. And you're going to check these things and see if they are okay. If they are okay, you tick under the Y for yes column. And if they are not okay, you tick no, it's not okay. It's not acceptable to tick no, I didn't look. So you check on the head, the neck, collar, chest, abdo, pelvis. We talked about these earlier. And any findings that you make relevant to it on that first initial top to toe, quite quick, what did you find? Then when you did your breathing and your circulation in your initial primary survey, along with ticking the box for the averages of, it was within these parameters, I was or wasn't worried. If you can fill in the boxes of pulse, respiratory rate, that's fine. You don't need to worry about blood pressure, temperature. But if you're working with an LRFR or a different kind of medic, then the very first recording can go in there. That would be really helpful. And the secondary survey box down the bottom is just for any further detail or treatment that you provide at this time. We've talked about this box. So on the right-hand side in the blank space, this is normally where you can write letters of the alphabet, as in A, airway, no concerns. B, for breathing, their breathing rate was this, it was short and shallow, or they had pain when they were breathing, whatever it might be. You can fill in the boxes in a logical way, or you can use arrows on the body map to exactly show where an injury was found. Equipment used. You should be writing this in the free notes rather than just ticking here. If you have packaged the patient, like one of the videos with, we put manual inline stabilization on the patient and put them onto a scoop where we packaged them with a Medi wrap to keep them warm and then transported them in a MIBS. You need to write that as a sentence so that people can clearly see what you did rather than just ticking a box. The tick in the box is to do with national auditing on kit that we use. Vaguely down the line means finances for Lowland Rescue. Observations. Now, if I skip back here, you've just written your observations on the bottom right-hand side. Please also write this on the very first one here. The squares have gone a bit wrong on this copy. They're all much easier to read than this. But please put the time and then pulse, blood pressure, respirations. SATs means oxygen saturation. So just do the ones that are within your scope of practice. That's absolutely fine. You don't need to worry about any of the GCS ones. You can just use AVPU and put it under eyes. It's fine. If you don't know how to do it, just leave it. But equally, if you're working with a bigger team that includes other medics, then anyone who's performing the scribe role can fill some things in. That's where it goes. Disposal sounds like you're going in a bin. Disposal means what did you do? I'm a bit particular about discharging patients at scene unless there's genuinely nothing wrong with them. We're quite protective about this in pre-hospital care. You don't have rights of discharge, so I suggest you phone somebody like me or peers, or just run it past somebody about why are you leaving them with nothing. If you leave them at scene under the care of the police, I'm quite happy about that. Or helicopter, ambulance, deceased on scene. That's all quite useful. The time here means the time that our care of the patient ended. Please make sure you fill that in. A bit like when we went back to the legal thing of the gentleman having a stroke in the police car. Yeah, but our care has ended. At the time of our care, this is what the patient was looking like. And then casualty carers. This is a bit difficult. At your level, STs are level 1, and that's fine, just tick the box. Or if there's multiple people, level 1 is ST, level 2 doesn't exist, and level 3 is LRFR. Tasking authority on the top right, the sort of police reference numbers, and remember to sign this piece of paper, please. They are confidential when they're completed, and they're completed in triplicate copies. We must keep them secure. So if you filled one in, please give it into the control van to keep it secure. Do not take it home, and they will make sure that it ends up with me or with peers, and we will submit them to Lowland Rescue. So they have to be kept for quite a long time. So the top copy can go to the patient, should go to the patient unless they refuse it. If they refuse it, please write that on it. It'd be very unusual. Also go to the patient with the ambulance. A middle copy we keep as a team, and the bottom copy Piers and I send to Lowland Rescue. So just give me and Piers the pink and yellow copies, that's fine. Let's go into this primary survey then. We'll do a brief overview, and the guys are going to jump in and put videos in to show you the skills in a moment. Let's do our first overview. So the purpose of the primary survey is to find and treat any immediately life-threatening problems. These are the problems that cannot wait. This is resuscitation. This is basic airway maneuvers. This is really catastrophic bleeding, those kind of things. We need to fix them now. The primary survey takes no longer than 90 seconds. Once we've excluded those life-threatening problems, we go back and we can make a bit more of a top-to-toe in-depth assessment. So again, you've done your dynamic risk assessment. Well done you. You've found a MISPA. Informed control that you've made a find. We're presuming a single casualty find here. Go back to your primary survey and then re-report that to control, preferably using an ATMIST. Let's talk about consent first. We've got to start our treatment. This is really simply the patient's permission for you to undertake an examination or procedure. In lots of the videos, you're going to see us doing this verbally. So do you mind if I take your pulse? Do you mind if I put my hands on you? You know, that kind of thing. Absolutely fine. Some of the responses might be non-verbal. So if you say, you know, can I take your pulse, and they offer you their wrist, then sort of implied non-verbal consent is fine. You guys don't do the high-risk surgical procedures where they go to the level of written consent, but it's not generally affecting our practice. So the capacity, this is their ability to consent. So does the individual concerned have an impairment of their mind or brain as a result of a condition, illness, or anything like drugs or alcohol? So an impairment of the functioning of their brain. Does this impairment or disturbance mean that this individual is unable to make the specific decision when they need to? This is all that you need to know about this. There are a vast array of further details that we can put in here. So if there's no impairment of their mind or brain, then this isn't an issue and they are allowed to refuse you. Having capacity to make decisions doesn't stop them from making unwise decisions like refusing medical care when it's needed. If they have that disturbance in their brain or mind, such as a dementia, not all dementia, it depends which level, then consent and capacity is decision specific. So by all means, if you offer them a cup of tea, they can say yes or no, that's fine. But when it comes to critical medical treatment, they might not have the ability to quite understand the risks and benefits to weigh up what decision they're making, in which case, if you need to make the decision for them, you must act in their best interests. So does the person, when you're assessing them, understand the information that you're giving them and the decision that they need to make? Can they then retain that information? So give it a couple of minutes to sink in. Do they remember that information, or are you having the same conversation again and again? And then are they able to really weigh up that information as part of the decision-making process and come to a decision? If somebody lacks these steps, then we can start acting in their best interests. Now, this becomes obvious with an unresponsive person. Do they have a disturbance in the mind or brain? Yes, they're not responsive. Is that stopping them from making a decision? Yes, it is. Do they understand any information? No, they're not conscious. Do they remember it or use it? No. Therefore, we would act in their best interests. So let's go on to our check cards. This very first patient assessment card. This is the one you're going to need for your assessments. So we always start with catastrophic hemorrhage. This isn't normal bleeding. Even normal bleeding, you hit the head and you can bleed quite a lot. Catastrophic means losing a life force of blood within minutes. When it comes to MISPAs, if this event has already happened, there will be little to nothing that you can do about it because of the level of the bleeding at the time. This is sort of impalement, loss of limb, massive destruction to your veins, arteries, those sorts of things. That being said, it can be caused by quite small injuries. If somebody falls and, for example, in our environment has a bit of stick go through their thigh and then they pull it out, that could quite easily rupture a massive femoral artery from which they will bleed a life force within about 3 minutes, and you can't put it back in once it's gone. So it's possible that you'll come across it, but unusual. The airway. With a consideration for the C-spine, airway comes first. So we're looking to look at the airway, make it clear, secure the airway. We're talking about head tilt, chin lift, or a jaw thrust, and we're going to teach you both of these things specifically with a video. The airway comes before any of these other things. If you don't have an airway, then no amount of fancy tools is going to make a difference. 100% of people without an airway will die. Breathing. We're looking for the really rough numbers here, and your check card tells you the answer. So now they're advising that you do a breathing check for 10 seconds and times it by 6. Now, I don't know about your math skills, but that's often beyond mine. If you find it easier, you can check breathing or pulses for 15 seconds and times it by 4. And if you get completely lost, do it for a full minute. The number we're looking for is how many times do they take a breath within 1 minute. That's the standard, breaths per minute or pulses per minute. And disability. So we're not talking about learning or any sort of physical disabilities. We're talking about neurology here. So we're talking about, are they conscious, or are they really confused, or do they only respond to pain? Are they unresponsive? Are they having a stroke? This is like acute disability, not long-term freestanding disabilities. That's not what we're looking at here. And the last bit is exposure and environment. All of our patients should be assumed to be cold, so wrap them up, and then either get them out of there or start completing your patient report forms. And this form here with your patient assessment helps you decide whether they're not time critical and you've got a bit more time, or they might be able to walk out, or if they're time critical and you really need to go. So I'm going to talk about this more later, but it's really, really obvious, like smell the blood from walking near the MISPA kind of obvious. You need to treat it before doing anything else, including CPR or airway, because there's no point doing either of those things if the patient doesn't have any blood left inside of them. This is the level of bleed that we are talking about. We'll talk about airway really briefly. Is there anything preventing the air going in and out of their lungs? Have they choked, for example? Consider their C-spine, but think about C-spine, but do airway. Save life here. It's just a consideration. For us, the most relevant will be people who hang, especially from a potential drop in height. Breathing. Air moves in and out of the lung. This is really good. Does the chest rise and fall? Does the chest rise and fall equally with the left lung and the right lung? This does mean that you are now expected to assess somebody's chest and look for bruising, bleeding, wounds, and you are going to need to touch people. At the bottom of this card is a breathing rate scale. So you can see the bottom one is per 1 minute, how many breaths per 1 minute, and that's the standard measurement that we're looking for. Is the heart pumping things round and round? Is the patient warm and generally pink? Is there any blood leaking from the patient? In which case, please stop that. So finding pulses, you're going to be taught and now expected to be able to find a pulse, a radial pulse or a peripheral pulse, which is on their wrist, and a central pulse on their neck, their carotid artery. And again, there's a matrix down at the bottom for finding out what pulses can be. Disability. Is the patient awake? Are they having a normal conversation? Are they confused? Are they drowsy? Any abnormality here is worth recording and going back and monitoring to see if it changes again. If they were unconscious on arrival and you opened their airway and did some bandaging on their bleeding and they suddenly started waking up, then this is a really good sign that your treatment is being effective. Exposure and environment. So everything else, top to toe, have a feel around their head, their shoulders, their arms. Is their tummy nice and soft and not rigid? Anything wrong with their legs? Think about temperature management. Chat with your team. Your team's there to help you and get going. If something changes or you do something to the patient, you do need to go back and reassess. So if you find a change in the patient's state, like their airway suddenly becomes really noisy, then you need to go and fix it now. If you've undertaken an intervention, so maybe you've put a broken limb in a splint, you need to make sure that they still have a capillary refill in their foot, for example, and that you haven't made it worse. This is the purpose of reassessment. So your reassessment under the casualty monitoring card gives you a really nice little tick sheet. So what time did you make the reassessment? A little tick about, is the airway secure? Are they still responsive? What are their numbers, breathing rate, pulse rate? It's really simple things, but things that you're now expected to do. And the card behind that then gives you normal parameters. Now, this is especially useful if your LRFR is having a really bad day with MISPA management and needs some help with either maths or remembering what normal values are. So we're going to go into catastrophic hemorrhage next. This is going to be the recognition of quite what that is. It's more than a big bleed, and we'll talk about the hemorrhage control ladder from starting small to working out that something's gone really, really wrong here. So we'll cover this in a practical session when you come in for an assessment, but otherwise the guys are going to show you a skills station in a minute. On your check cards, this is right at the top of your check card under life-threatening bleed. And it's going to talk you through things like direct pressure, put your hands over it and squeeze it really tight. Indirect pressure is a bit more complicated. We're looking at veins and obstructing blood flow to applying things like tourniquets and really getting control of your bleeding here. Recognition of the catastrophic hemorrhage is really that you don't need to find it, it's going to find you. This is a massive bleed, arterial, that goes really, really far. So we're going to go and watch this video. So we're back into the hemorrhage control ladder. This is right at the bottom when you're talking about direct pressure. Either put your hands over it or start with some bandaging. If it bleeds through, you need to put another bandage in on top of it. Don't take the first one off. The first clots that you get are going to be the best clots that you get. When we're talking about indirect pressure, if I'm bleeding from here, this is going further up from your bleed and it's finding veins, arteries to obstruct with your thumbs and fingers. It's quite a fine art and it's something that we'll look at in person. After this, the LRFRs and the team have hemostatics. This is a bit of gauze and it's impregnated with things that facilitate clotting, so it's really good for holes, stabs, fall onto an impalement, stick, those kind of things. And after that we move into tourniquets. Tourniquets are really serious, but they absolutely have a place. So direct pressure and elevation. This is a poor picture. The patient's boot is still on, but at this stage we're not particularly interested in the capillary refill, their pulses in their feet. If this is a critical hemorrhage kind of situation, we're all about controlling a life-threatening bleed. Get your hands around this and start controlling it. So let's talk about tourniquets. You've tried really good bandaging technique, you've tried direct pressure, and none of this is working for you. So you're going to go on to using a tourniquet. It needs to be above the site of injury, closest to the heart, and it needs to be as tight as you can. Tourniquets are incredibly painful to apply, but if they really are losing a life force of blood, they definitely have a place for us to put them on. If you're using a tourniquet, the most important thing is it needs to be skin to skin. You must not put them over clothes, they won't work. And preferably put the time that you place the tourniquet. There's a place to write it on the tourniquet, so we know time of application. This is really important later when the patient potentially goes for surgical treatment and removing of their tourniquet. So this is all treated under action card 3. So if you look at your pack of action cards and have a read down.
Sure, just apply pressure for that to me, that's it, just elevate it and keep it there for me, thank you. I'm just going to get this very bandage. Okay, just bring it down slightly. Okay, when I apply this bandage, just slowly remove it, that's it. Straight onto the wounds. Okay. It's nice and tight. Okay, sit and just support.
So we're going to go on to airway management. For this, we're going to recognise an airway that's patent, one that might be at risk, and obstructed airways. We'll talk briefly about choking as well. We're going to talk about the use of the airway ladder. Lots of things are a ladder. You can go up and down the ladder. If something was working and you escalated and now it's a problem, go back to the last thing that worked. The basics for airway management, like head tilt, chin lift and jaw thrust, these are the things that make a difference. So on our assessment check cards, again, we're right up at patient assessment and we're here, right at the top on airway. We're looking, clearing and securing airways. And there's different methods that we can use depending on if the patient is a medical patient who might be unconscious with a poorly airway, or a trauma patient who might be injured and have a different reason for their airway problem. So we start normally patent. Patent is good. This is a nice normal airway, it doesn't concern us. Recognising airways that are at risk is the most important thing here. So the patient might be well for the moment now, but there's certain things about what's happened to them and the situational context that think this might become a problem in a minute. What if they should vomit and they are tied down to a scoop? This is an at-risk airway. Obstructed airways are a big problem. This is requiring an airway adjunct to get toys out, or obstructed as in we're now dealing with a choke or a choke into cardiac arrest. So patient airway, this is your patient, they're alert, they're chatting away to you, there's no noises in their airway, you can't hear them wheezing, you can't hear a horrible whistling stride, or they're not gurgling, nothing horrible going on here. When we talk about at-risk airway, we're talking about any patient with an altered level of consciousness. This could include things like knocks to the head, where they've gone a little bit strange. It's just to be aware that should their level of consciousness deteriorate, the airway is the next thing that's coming your way. Other patients to be aware of are airway burns. Those who've had a smoke inhalation are a huge risk. People who look fine now and can rapidly deteriorate with you. And the last one on this is anaphylaxis, so life-threatening allergic reactions. And this one is to be really hot on the phone to 999. Ask them about EpiPens. There's very little at your level you're going to be able to do for this airway without medication and support, but it's being aware that it's a problem. Obstructed airways are two things. They're either noisy and partially obstructed, and you can hear gurgling, you can hear whistling, stridors, or they are completely obstructed, which is silent. Somebody who is genuinely choking is silent, they don't cough. So potential obstructions are foreign bodies, or it could be liquids, bloods, vomits, or their own tongue, depending on how they're led on the floor. So when we look at choking, we're looking at different actions to understand the severity of the problem. So if it's mild, then they'll be coughing still, they're definitely still conscious, and you need to encourage them slightly aggressively to cough it up, change their position, lean them forward. And you're looking at things like back blows to try and relieve any choke along with their coughing. If it's really severe and they look like they're trying to cough but nothing is being produced from it, then we need to move on from back blows, abdominal thrusts, and keep moving between the two of them. 5 each time of each before you move on to the next thing. Really check to see if you've got rid of that choke, because too many of these is damaging, but it's got to be gone. If you can't get rid of this choke, they will deteriorate into a cardiac arrest, in which case you treat it as normal. 30 to 2, try your ventilations anyway, because you might be able to force some air past it, that's not a problem. But you're going to treat it once they go unconscious as if it's a cardiac arrest. So the airway ladder, starting at the bottom with things like positioning. Now you guys can all do this. This is head tilt chin lift, this is your jaw thrust, and we're going to show you a demonstration of what these things look like and a good technique for them in a minute. When you get your LRFRs along, they've got a lot more things to help. They've got NPAs, OPAs and eye gels. Eye gels particularly for resuscitation. Alongside that is suction, and for you guys what that means is gravity is wonderful. Roll the patient over. If they're being sick, don't leave sick people flat on their back, they'll choke. Roll them over, let gravity and posture do the work for you, and the LFRs can always come along and top up with oxygen. If you've done airway management, this patient must be on oxygen as soon as possible. After you've done any intervention for their airway, you need to reassess it, because just because it's gone silent doesn't mean that you've made it better. If it's gone silent, have you obstructed your patient? So really go back and make sure that you haven't created a problem that we didn't need to. So positioning. We'll do a head tilt chin lift, which is things done together. So it's 2 fingers under the jaw and a hand on the forehead, and you just tilt the head up. And a jaw thrust. A jaw thrust is for a big trauma patient, significant head injuries, where you have a real and genuine concern about their C-spine. Airway comes first, but there is a technique that we can use to try and get out of moving the neck so much, and this is a jaw thrust. We'll show you.
Head tilt. Fingers on the bony part of the jaw, applying on top of the head, and tilt. Checking the airways open. Jaw thrust. Flying the corner of the jaw, applying reaches on the cheeks, pushing the jaw up, opening the mouth.
So you've done your head tilt or you've done a jaw thrust, whichever it is that you felt you needed. You've made an intervention, which means you need to go back and reassess. Start from the beginning. Is the patient breathing? You really need to be certain that is it gone quiet, it's not because they haven't stopped breathing. Have you made it worse? Do you need to go back to a different technique? Or have you not achieved resolving their at-risk airway yet and you need to change technique or seek further support? The last thing that we talked about briefly was suction, and for you guys without the kit, that means postural drainage. So we're going to go into another demonstration video.
Okay, Sean, I'll take the head.
Yeah, it's going to move his arm up the way. Bring this arm up.
Ready, brace, roll.
Hi James, I'm Casper. You seem to be struggling to breathe. Okay, can you cough? Okay, I'm going to slap your back. Okay, nothing's come out. I'm going to try a abdominal thrust. My thumb out, in and up. Cough, James. Right, there's nothing come out. James, right. James now collapsed. James, can you hear me? Can you hear me? Check his airway. He's now not breathing. So this is a cardiac arrest. I'm going to get the defib.
We're going to go on to basic life support. Now you guys have done this before, but this time you have to be able to demonstrate this in your assessment day. This is demonstrating high quality CPR, safe use of an AED, and you need to be able to achieve this for adults and for children. Today we're also going to discuss a little bit about infants. Extremely unlikely for us to encounter it in search and rescue, but each their own in their own life. So we're looking at what makes safe and effective basic life support. All this needs is your pocket mask to deliver rescue breaths. Now, in COVID times, resuscitation does not include ventilation and rescue breaths. No breaths in COVID. Prior to COVID, you do 30 compressions to 2 rescue breaths. They do remain a bit of a choice if you're a non-professional medic, if you want to deliver rescue breaths. And we're going to talk about AEDs, what they are, how you use them, and how they work with children as well. So we're looking at the chain of survival. Now, this is where you kick in for the first stages of this. In fact, most of this. This is the fact that somebody goes into cardiac arrest or is unconscious, and you, somebody else, needs to recognise that that patient is or is not breathing. So we need early recognition of the cardiac arrest as soon as possible. Not breathing at all, or not breathing normally. So remember when we talked about breathing and we talked about less than 10 breaths a minute was a problem. If you get somebody breathing at, say, 4 breaths a minute, 1 breath in 15 seconds, and it's loud, it's snoring, looks like a fish out of water. This is agonal breathing, it's not life-sustaining. You start your CPR. The next stage is early CPR in the chain of survival, and really excellence at the basic skills. This is chest compressions. You need to make that blood go round and round. And it's not just about pushing the chest down, it's about coming back off the chest and allowing the heart to refill with blood so that when you push again, something is going round. The next stage is early defibrillation. While CPR preserves a person in a state that life may come back, it provides oxygen to their brain and their blood supply. Defibrillation is the only thing that's going to fix this, unless there's a really unusual cause of cardiac arrest. So early defibrillation is really important. If you have a defib, put it on really early. Adults and children. Children, when the defib says shock, you push the button, they need it. The last part of this is all about post-resuscitation care. Even when you call the ambulances, it's very little to do with drugs. It's all about the treatment, the excellence of the basics, and getting to hospital to reverse what happened in the first place. So in Europe, every 45 seconds a cardiac arrest takes place, and bystander CPR is the vital intervention in survival from this before professional medical help. And early resuscitation, prompt defibrillation within that 1 or 2 minutes can result in a 60% survival rate. Currently, in this area of the UK, the survival rate is this year 11% of out-of-hospital cardiac arrests. So by recognising this really early, we can do a lot about this. So you find your unconscious casualty, unresponsive casualty, and you do your dynamic risk assessment like you always would. Make sure it's safe for you and the team. Inform the control that you found somebody. Go and make a little assessment. We're assuming you've got 1 patient here. It's really unlikely to have more. Inform control that you made the find. Do your primary survey of, hello, can you hear me? Wake them up, find an airway, and work out what you've going on. So CPR is cardiopulmonary resuscitation, and what we're trying to do is circulate the blood and oxygen to keep the patient in a status of which we could regain life. We start CPR for an unresponsive person with an open airway who is not breathing or not breathing normally. that's it. Unresponsive, not breathing, straight on the chest. And if you have a defib, straight with the defib and then on the chest. We don't start CPR for a really limited amount of criteria. And this is where we can recognise life is extinct. Even you guys at your level, is absolutely appropriate in some circumstances. And there are 5 really big ones. This is, they don't have a head, decapitation, that's absolutely fine. We're not going to start that, that seems really clear. They are grossly, largely chopped in half, as in missing a significant amount of chest or torso. It doesn't matter which way they're chopped in half, we're not going to start as non-survivable injury. If they are in a fire, we're not just talking about burns here, we're talking about incineration, charcoal. There's no coming back for a full body char. We're talking about any patient that is mouldy, they're putrefied, they've been there for so long that they've lost fingernails. It's really quite unpleasant, but you'll know it when you find it, and they are so far gone there's no intervention to be made here. And the last one of this is a patient that is a bit more complex. They are witnessed, known to have been underwater for more than 90 minutes. So it must be witnessed that they went in the first place and that nobody has seen them pop up again. This isn't somebody swimming around and not doing very well, this is underwater, submersion, not immersion. After 90 minutes this becomes recovery, not rescue. And we won't be doing a drowning resuscitation after that time threshold. When we stop CPR, there's some limited reasons. Physical exhaustion, but knowing that if you stop, that's it for that patient, that's fine. If you physically can't continue. If there's bystanders who are really aggressive and prevent you from providing care, I mean, bring out the charisma, you need to get to that patient, but you're not going to endanger yourself. Very unusual, really haven't encountered that at that stage. If the patient shows sign of life, please get off. Any waking up, any return of breathing by themselves, that's really, really great. Then you're going to stop your CPR. Other than that, it's really not an awful lot. We need to keep going until they come back to life or we reach an unstoppable point. For you guys, you're going to keep going no matter how long you've been going for until a registered professional tells you that you can stop. So if the ambulance or even a team paramedic actually turns up and says, we're now beyond all hope, then that person may make a decision to stop, other than those big 5 criteria. So you've done your primary survey, you've done, hello, can you hear me, open your eyes, they're unresponsive, you opened their airway, and let's make it really clear, this patient's not breathing. Okay, you're going to go straight away. If you have a defib with you, put the defib on. So cut the clothing, put the defib on, start your CPR, turn the defib on, let it do its analysing. If you haven't got a defib, you're just going to go straight into CPR. For an adult, straight into compressions. 32 compressions to 2 rescue breaths. Remember, in COVID, there are no rescue breaths. So this is card 2 on your check cards. If you flick onto it, there's a nice little process going down the side. Now, there's a lot of blurring out on this card at the ST level, but it's really helpful if your LRFR is with you. They can still use your check cards to give them a prompt. This is a high stress situation, so help each other out. This is a team game. So you arrive with an AED and you put it on, or if you're a 2-man team, great, one of you do compressions and one of you work around and put the defib on around them. That's really nice. We're normally in a team. Let the defib do its thing and tell you shock or no shock. If it's a child or a drowning that we are going to work on, then the first thing you need to do is give 5 rescue breaths. Now this is complicated because this is COVID times and we're not going to do that in COVID times. Should we change in the future, or how we used to be, you would have given 5 rescue breaths and then carried on. The ambulance service will continue to give rescue breaths, but we have a device that we're able to use to achieve that safely, and you guys don't. You've got your pocket masks and that's it. If you're doing rescue breaths, PPE is really necessary, and currently we haven't got a high enough level to be doing rescue breaths, so as COVID continues we're going to ignore that. For children and infants, we're going to do 15 compressions to 2 rescue breaths. So we count a child as an under 12-year-old or pre-puberty. It's a rough estimate. If they're the same size as you, some children are quite big, then treat them like an adult. Won't do any harm, but preferably if it's an obvious child, you can do 15 compressions to 2 rescue breaths. Use an appropriate amount of force. If it's quite a little child, just use 1 hand. If it's an infant and you could cradle it in arms, you're going to use 2 fingers or your thumbs. So,
AEDs, so automated external defibrillators. They're really, really safe to use. You can't shock somebody who doesn't need it. You can apply it to me right now and press the button as much as you like and it wouldn't make a difference. So they will tell you whether it's a shockable heart rhythm or a non-shockable heart rhythm. You can use them on all sorts of patients. We're just going to go through some of the risks. So if they're wet, you need to dry your patient off. So in the little prep bag that comes with your AED, you have a cloth to be able to wipe your patient down. If you pulled out a river, they're not going to be perfectly dry. We're just talking about pad to pad placement. Try and dry that pathway because of electricity. If they're really, really hairy, you need to shave their chest. With your defib in the pack is a dry shave razor. So just where the pads go, you don't need to give a whole chest treatment. You need to just give them a quick dry shave and then pop your pads on. The pads need to adhere really well to the dry skin. If they've got medication patches or other things like that around them, just take it off. Don't worry about sticking it back on the patient. Just take it off and move it out of your way. The only reason is some of the medications have bits of metal, things like that in them. There's no other massive issue. Check for pacemakers. They're really obvious, little box. It sits under the skin, but it will stand up and be an obvious box. They're normally just on this side, just above the heart, so it doesn't actually interfere in your defib placement pads. But you can have them on the right hand side. You just need to adjust your pad placement and try to give it a bit of space. Any jewellery that's going to cross that electricity path, just get rid of it. Or if it's a necklace, just move it up out of the path. You don't need to necessarily cut things off and lose precious items. And if you're with an LRFR or a full medic team and they're using oxygen, when a shock is delivered, the open source of oxygen needs to be moved a metre away from the patient. That's as simple as just moving it behind you, no further than that. So pad placement is top right hand shoulder of the patient's right hand side to under the armpit around the side of the left hand side of the chest. You want it to be right around the side so that the shock goes through the heart, not just sitting on top of the chest, as it doesn't give us any value. So deliver a safe shock if it's indicated, and the defib will tell you this. You don't need to do any guesswork. It will say shock advised and it will automatically start charging and it will let you know when it's ready. It is your responsibility to make sure it's safe to deliver the shock. That is, you're going to push the button. When you push the button, look at the patient to make sure nobody comes back and tries to deliver skills or touches the patient. So you check the top of the patient, the middle of the patient, the bottom of the patient. Really loud and clear, finger on the button, stand clear, push a button. Okay, we must be really safe with defib shocks. The defib will auto cycle every 2 minutes, it will reanalyze. Now this is really useful because with your CPR provider, you're only going to do 2 minutes each. After 2 minutes, your efficiency drops significantly. There are no heroes of CPR on the chest. Get off and let somebody else who's fresh take a turn. So if we're doing a resus in our field, lots of team members will turn up to help and everybody needs to be kit off, jumpers off, ready to provide 2 consistent minutes of care. The defib will analyse, change in a fresh provider, shock or no shock, and carry on. Works really nicely. So we're going to do a demonstration of an adult CPR with rescue breaths and AED, and then we're also going to do one for children as well. Just remember, in COVID times, we're not doing rescue breaths.
Checking for danger. Any danger? No danger. Okay, hello, can you hear me? Hello, can you hear me? Can you open your eyes for me? Okay, no response. Check the breath. Tilt the head. Looking for the rise and fall of the chest. Holding for 10 seconds. No breath. Putting the defib on straight away. Turning it on.
Call emergency medical services now.
Get my mobile device out.
Mode.
Call for
Follow the voice prompt calmly.
an ambulance. Get that on
Remove all
route.
clothing from chest and stomach. Rip clothing if necessary. Do not touch the patient.
Stand clear.
Analysing heart rhythm. Shock advised.
Top,
Stand
middle,
clear.
bottom.
Press
Stand clear.
orange
Stand clear.
button
Shocking
now.
now.
Shock delivered.
Shocking delivered back on the chest.
Begin CPR now. First.
Again, looking for the rise and fall of the chest.
Do not touch the patient. Analysing heart rhythm.
Off the patient.
Shock advised.
Top, middle, bottom. Stand clear, stand clear.
Shock delivered.
Shock delivered, back on the chest.
Begin CPR now. Press the flashing blue I button for first.
Okay, coming in, checking for any danger, checking the scene safe. Hello, can you hear me? Hello? Open your eyes. Hello? No response. Okay, just checking the airway, head tilt, chin lift. Checking for breathing, 10 seconds, look, listen, feel. Okay, patient's not breathing, I'm going to apply the defib. I'm going to, but because it's a child, I'm going to go straight in with 5 rescue breaths. So I'm going to get my pocket mask, just pop that on. Head tilt, chin lift. So 5 rescue breaths.
Call emergency medical services now. Pediatric mode. Follow the voice prompt calmly. Remove all clothing from chest and stomach. Rip clothing if necessary. Take out the pads from the bottom of the device.
Okay, it's on front and back.
Do not touch the patient.
Okay, everyone hands off.
Analysing heart rhythm. Shock advised. Stand clear. Press the flashing orange button
Okay.
now.
Everyone clear,
Deliver
top, middle,
shock.
bottom, shock delivered.
Delivered. Begin CPR now. Press the flashing blue I button
14,
for
15.
CPR voice prompt. Reanalyzing heart rhythm in 2 minutes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Do not touch the patient. Analyzing heart rhythm.
Analysing, hands off.
Shock advised. Stand
Okay,
clear.
top, middle,
Press the
bottom,
flashing
everybody
orange
clear?
Button.
Shock delivered.
Delivered.
Back on. 1, 2, 3, 4,
Begin
5,
CPR
6, 7,
now.
8, 9.
Press the
So let's go on to the C-spine. This is really brief. The priority here is always airway. So we'll look at high risk mechanism of injury to make you think that you need to be concerned about a C-spine in the first place. And we're going to look at real big risk factors. The risk factors are huge, anything from drugs and alcohol to general intoxication. This can also include head injuries that cause a change of behaviour. If it's a significant blow to the head or they've fallen from something, you need to be aware of it. Anything called axial loading, this is direct blow on top of the head. It's a traditional sort of diving injury, but you can have it from other injuries. That's a real concern because you've compressed your spine. Anybody who complains of complete numbness, tingling, pins and needles, you need to be aware of that. That's a risk factor. Things to do with vehicles. It's not very common, but we have gone looking for people who have absconded from RTCs before, in which case we need to know roughly, is it a high-speed collision? Have they come to a scattered stop where they sort of roll around and slow down slowly, or have they hit the biggest oak tree and stopped? The oak tree is the problem solution here. Anything that's a rollover, any person that has been ejected from a vehicle that crashes, as in thrown out of the vehicle, this is a massive problem for you. Anyone who is a pedal cyclist or a pedestrian hit by a motor vehicle, it's a risk, it's a dangerous mechanism, you just need to think sensibly about it. Anyone who is 65 or older is instantly in our risk category. It's quite young these days. And anyone who tells you that they have a known spinal degeneration disease, any arthritis, any surgeries, do they have curvature of the spine? These are all the kind of people that are really high risk, and you just need to remember to ask about it. Other than that, we're not interested in collars, we're interested in the kit-free basic mechanisms that we can do to preserve a C-spine. And by this, we're talking about manual inline stabilisation. Hold on to the head yourself. So we're going to go into a skill session.
Right guys, I'm going to go Mills. I'm going to bring my hands underneath the head. I'm not covering the ears, I'm going to spread my fingers out underneath the head so the head's actually resting on my fingers. Right guys, hands on. So what we're going to do, we're going to move to the left first of all guys. Everyone okay with that? Anyone that's not ready? Ready, brace, roll. Ready, brace, lower. Alright guys, if you get around the other side for me please. Anyone that's not ready? Ready, brace, roll.
Head is secure. Feet is secure.
Ready, brace, lower.
Let's go into a breathing session. So we'll do the assessment of breathing and how to take a respiratory rate. This is now expected at ST level for everyone. So again, using your check cards on that first initial page, there's an element in it for breathing. Really, you take there, how many breaths do they take in a minute? You can do that in shorter version if the patient's really serious or you haven't got a lot of time. You can do how many breaths do they take in 15 seconds? Just times it by 4 and you'll get the answer of breaths per minute, which is the measurement that we're looking for. Anything from 10 to 20, absolutely fine. I'm not bothered by that at all. If you get a patient who starts breathing less than 10, there's a problem, you need help. We're going to start breathing for this patient potentially. That's not enough for life-sustaining breaths. If you get a patient who most definitely breathes more than 30 breaths per minute, there's another problem. It's harder to do anything about it, but that's not normal. For you guys, there's a big assessment that the LRFRs do, and you're not expected to do the same, but there's some elements that you are now expected to look at. And this is having a feel around the neck, the chest, the lungs, and you're feeling for deformity, you're feeling for broken bones, or you might find a bit of stick sticking out of a lung. And then you're going to have a look at the chest. This does mean that you need to look at the skin. So ask the patient for permission, say, I just need to have a little look at your chest, I need to make sure you haven't got any injuries. And you're looking for things like any sign of bleeding, you're looking for really big bruising patterns, anything strange or unusual, you need to then be reporting on that. The most important thing is your chest is not just the front of your body. You need to check right up the sides into somebody's armpit, and you definitely need to check their back if you can. If you're moving the patient to roll them anyway, it's a really good opportunity to lift their shirt and have a look down their back. Otherwise, there's techniques that you can use to be able to assess somebody's back if they're not conscious or you don't want to move them whilst they are flat on the floor. And we're going to go and show you that now.
Hi JT, I'm James. I'm just going to check your breathing in your chest to see if you've got any injuries. Is that okay?
That's fine.
Okay, I'm just going to start by taking your rest rate. So what I want you to do is just breathe normally for me while I just count your breathing.
Yep.
Okay? Okay, that's 15 seconds. In that time you took 5 breaths. So I'm just going to times that by 4. It gives me 20 breaths per minute. That's great. Thank you. Right, now I'm just going to have a feel of your chest. Is that okay? I'm going to place my hands on and just check all over. Okay, so I'm just going to first off just feel for any deformities, anything that's not intact, any sort of broken bones, floating ribs, or anything that doesn't feel normal, any sort of crunching noises. Now I'm just going to feel for a rise. So just take a deep breath for me. Good, and I've got equal rise on both sides, and that looked normal. So then I'm going to have a look around. Do you mind if I just move your shirt and look underneath so I can look for it? Okay, so I'm going to look under here. I'm just going to have a look around on your chest. I'm looking for any bruising, any marks, any sort of blackish areas. Looking for any wounds, anything that where you might have injured your chest, anything that's stabbed in it. I'm also looking for any bubbles or anything like that. I'm just going to also look from the bottom, and so I can look up in the sides. So I'm just going to expose up here. And just having a look all the way up into your sides, into the armpits again, just running my gloved hand down there as well, and this side just checking right up in the armpits, and again looking for any of those bruising deformities or wounds. And then if you could just lean forward for me, I'm just going to do the same on your back. Thank you. Again, just lifting the top up and exposing fully, and just looking again for any bruising or anything unusual really, and just check that there's nothing wrong there, and that all looks fine. Pop that back down. Thank you very much, JT.
Fine.
Let's go on to circulation. So we're going to look at how do you assess this, what pulses do you need to be able to find, where is it appropriate to take a pulse, and then we'll do special approaches for different types of hemorrhage. So again, this is still on that same first page on your check cards where it suggests what pulse rates might be normal. I think in your head it's really easy to say anything less than 50 beats in 1 minute is a dangerous problem. Anything more than 120 starts to get a little bit unnerving, and they'll probably have some sort of shock, trauma or bleeding. So we're going to look at peripheral pulses, which means pulses away from the heart. And for you guys, this means down at the wrist here. So we're looking at whether the rate of their pulse is really fast or really slow. We want that number. Again, the same as breathing, you can do how many beats do you feel in 15 seconds and times it by 4. The standard of measurement we're looking for is beats per minute. That's what we're recording. If you get really lost, you can sit there for a whole minute and count a pulse. That's not a problem. We're looking at whether the pulse beat that you can feel, is it regular and consistent, or every now and again is it irregular? Does it seem to be off time, skip a beat, those kind of things? You don't need to do any diagnosing, just a simple report of feels regular is absolutely fine. And then is it a really strong bounding pulse that you can feel, or actually is it really difficult to find and really, really weak? If your patient's bled a lot, it would be unsurprising that their blood pressure might be a bit low and they might have a slightly weaker pulse. Again, when we talk about circulation, we always talk about temperature management. In the search and rescue world, all of our patients are cold. It's cold being on the ground. So get out your wraps, get out your layers, and make sure you keep your patient cozy. You're looking for, by touching their skin, are they warm, are they cold, are they clammy, do they sweat? All of those kind of things, so that you can take care of your patient. Skin colour is things like, are they nice and pink, are they healthy, have they gone really, really pale, have they got bluish purple fingertips? All of these are sort of bad signs. And capillary refill. So for you guys, this is take a finger and you just squeeze your fingernail for 5 seconds. This should make your fingernail go white. If you let go of this and you count how quickly your fingernail goes pink, it should be less than 2 seconds, it's quite normal.
Hi Sean, I'm JT. Do you mind if I take your pulse? Lovely. So what I'm going to do, I'm going to take a radial pulse. So what I usually do, I put my 2 fingers on the thumb, slide it down the thumb till you get to the wrist, then you'll pick up the pulse. The rate at the moment seems quite normal. It's not too fast and it's not too slow. The rhythm is regular. It's very strong pulse, not weak pulse. So what I'm going to do, Sean, I'm going to 15 seconds and I'm going to count your pulse. Just relax for me, yeah? So right, that was 15 seconds, that was 20, so times that by 4, that's 80. So that's a nice strong pulse. So what we're going to do next, we're going to do the centre. So what I usually do, I usually start off round by the ear, follow the jawline down using 2 fingers. You don't want to put too much pressure on, and you'll find it. As nice strong, not too weak, not too fast, nice strong pulse there. Your skin feels a bit, he doesn't feel clammy, so your skin feels a bit cold. So what we're going to do, I'm going to put a blanket on you, Sean, okay, get you nice and warm. You can just lean forward for me, Sean. There you go, lean back for me. There you go, keep that wrapped around you.
Very briefly, we're going to discuss disability in a bit further detail, and most specifically, I need you to be able to conduct a fast test to be able to rule in or out a stroke. This is the point on your check card. Mostly we're talking about level of responsiveness or level of consciousness. A for alert, voice, pain, unresponsive. There are new things about new confusion, but it can be difficult to assess. When we're talking about the AVPU scale, alert is not necessarily orientated to time or place. So a person with dementia can be alert but don't necessarily know who or where they might be or what's going on. Somebody that's only verbally responsive, this means that you are doing the verbal response. So somebody's on the floor and they don't look at you when you walk over, but you shout their name and now their eyes open looking towards you, although they may be a bit confused. If you walk over to the same person and they don't look at you and you look at them, talk to them, and you get nothing, and you have to put hands on the patient to try and wake them up, this is pain response. And it is pain that we're looking for rather than sort of a light little tap. This is appropriate pain, I must add, and there are very specific ways that we do that. If none of this works, by the time you get there, you really want to be able to wake this person up, if there's any way that you're going to do that. And if you can't, then we go that they are unresponsive, unconscious with no responses at all. So let's go and have a look at stroke.
Okay, JT, I'm James. I just want to check you over. So you've got something that maybe feels like a bit of an unknown illness. So I'm just looking at my card 19 for unknown illness. I'm just going to look at a fast test just to rule in or out a stroke. So I just want to start with your face, please. If you could give me a big smile. Yeah, okay, great. Now try and puff your cheeks up. Well, wonderful. Okay, right, arms, please. Can you put your arms out? Okay, I want you to grip my hands really hard. Okay, pull me towards you. Okay, push me away from you. Okay, thank you. Now just keep your arms there, close your eyes, just keep your arms level. That's great, thank you. Just pop your arms back down. And now I just want you to just speak normally. So I just want to say where you are today.
Monument Way, Woking.
Wonderful, that's great. Thank you very much.
Let's do exposure, environment, and everything else, including a bit of hypothermia. But we're now also going to look at your secondary survey. So you've done all of this about primary survey and immediately life-threatening issues. Your secondary survey is really simple at this sort of level, but we're looking at, you've exposed the patient, you've checked all over because you followed this patient assessment card, you've done a proper breathing check, you've checked their circulation, and also start inquiring about the patient if you haven't done so already using a history-taking mnemonic. We're going to use sample, we'll come on to that in a bit, but essentially you need to know about the medical history of the patient, any medicines that they might take, allergies, those sorts of things. This is your secondary survey. There are areas of the body and the person that you need to check to make sure that we haven't missed anything that would make the patient unwell. And generally we start and we call it a top to toe. So start with the patient's head, including their face for any injuries. And you need to put hands on the patient. So have a feel around their head and you're looking for big denting or cuts, bleeds, all those sorts of things. Their neck, they haven't got any wounds on it. Collarbones and shoulders. You'll have done a lot of assessment of their chest when you did their breathing assessment, but it's also a really good opportunity to reassess that if you did your primary survey a little while ago now. Abdomen check for you is really, really simple. It's just a very gentle feel of their tummy, and all you're looking for is that its tummy should be soft and squishy, not rigid, sort of guarding. That's a bad sign. You just need to be able to write it down and report it. Their pelvis, we're looking at big mechanisms of injury to fracture a pelvis, but it's a really big deal, and the LRFRs carry pelvic binders to be able to prevent internal bleeding or slow down internal bleeding. For you guys, don't go springing about and leaning on people's pelvises. That will make it worse. It's just assessing whether they've got any pain in that area of the body. Extremities, we're talking about arms and legs, so just have a quick feel down, shoulders to wrists, from waist to feet, to make sure that there's no injuries. And it's a good idea to appropriately just roll sleeves up or trousers and actually have a look at what you're doing, not just running your hands down things. Any opportunity you have to check the patient's back. Now, if they are not particularly injured, they might be able to help you, or quite willing that you lift their shirt and have a quick look. But also looking for things like back pain. Just because they haven't hurt their C-spine doesn't necessarily mean that they haven't hurt their back. So it's just to be aware of injuries, bruising, or back pain, and that might influence your decision about how you're going to get out of there. We'll come on to inquiry and the sample history form. You'll be relieved to know there's a check card for this so that you don't have to remember off the top of your head. Example starts with signs and symptoms. Now we've been over what the difference here is. Sign is something that you can see, like bleeding. A symptom is something that the person feels, like nausea. And just write anything that's relevant that they're complaining of at the time. Remember, if they complain of pain, we want you to do a pain score. So if 0 is no pain at all and 10 out of 10 is the worst pain they would ever experience, where they place themselves right now. Allergies includes, very specifically, we want to know about allergies to medication, but we're also happy that you write things about allergies to food or insects or any other things like that. Medicines, this is ones that the patient takes. These can be prescribed medications. They can be over the counter, like they might have had a bit of paracetamol for some reason this morning, or it does also include illicit drugs. If the patient lets you know that they have had something that they probably shouldn't have done, that's fine, we're not going to judge that, but we are going to make a recording that they have had that. Maybe a very polite question about, is that normal for them to take that drug? And that's it, we leave it at that and we just document that. Past medical history, this is about the patient. So if they take a medicine, they have past medical history. We quite frequently get patients who take medicines for blood pressure but no longer say that they have a blood pressure problem because they take a medicine of it that made it better. No, they still have a blood pressure issue, for example. So anyone who's taking medicines has past medical history. It also includes things like past surgeries. Might include that in there too. The last time that they ate or drank, this is oral intake. So approximately is fine. So in the last 1 hour, 4 hours, 6 hours, anything like that. It's useful if you find out that they're diabetic, that it might be that they're confused because they haven't eaten something. It might be that they are really severely injured and are going to go for surgery, in which case the surgeons and anaesthetists need to know the last time that they ate or drank, because it is a serious risk of anaesthesia. And at the bottom, we want a very short story, as in a sentence of what happened, what are the events leading up to the incident, do they know what happened, can they explain it to you? But try and be really concise here. Hypothermia is really important. Even in the UK, even in the summer, we all go hiding for the dog team, and sitting on the ground for a long time, even in summer, down in the shade, down in the forest, is quite chilly. Hypothermia is really important when we're talking about people who are injured, because if they're really cold, then we start to get ineffective blood clotting, which means no matter how excellent your bandaging skills, nothing's really going to change until we get warm here. And the biggest risk when we start getting below 30 degrees is risk of arrhythmias. These are life-threatening heart rhythms. This is where people who have been out, led on the floor, and might be wet or in water, they're particular risk, or out for exposed for a very long amount of time, missing for a long amount of time. It doesn't need to be a recorded specific number. If they're cold to touch, they are cold, and that's fine. You're going to help deal with that, whether it's protecting from wind, you need to protect from rain, you need to protect from cold. So wind and wet is really, really dangerous for hypothermia. So try and mitigate some of those things. Put layers on them. Try not to give up too much of your own clothes or any of your own clothes. And we all carry things like medi wraps, foil blankets. We'll do something for wind, but won't warm anyone. So just have a think about what you're carrying on you and what you could do to start warming people up. We have better things like the CAS bag. That's nice and cozy, and get people warmed up a bit quicker, especially during extrication. The last thing to remember is to see that if they have to stay on the floor for some reason, if they're injured or can't get up, or you need to extricate, then try and think about insulating them from the ground. Whether that is, you can put a little layer underneath them. It could just be jackets underneath them and roll them back over on the top. Although if you're using your own clothing, remember that if the patient's bleeding, it's going to all become contaminated. And then layers over the top is the final thing that we need to consider whilst we're maintaining a patient where they are.
Let's go into packaging and evacuation. So we're going to talk about what methods we have for packaging and getting people out of places, choosing the right stretcher or the right piece of kit, choosing to walk somebody as part of your packaging choices, and really careful casualty handling. So we'll do a demonstration of this in a little minute. We need to get this right. So the right casualty, the right condition. Why are you carrying somebody out in the first place? If you don't need to, then don't. Try and find the right route out of there, get people planning the paths that you're going to use, clearing things. Is it dark? Do you need torches to light your paths? All of these things are really good considerations. Where's your ambulance coming to? Because if you're carrying somebody, I'm assuming that you've called one, use the right communication. Carrying people out requires a lot of team effort. When we do a long carry, we need rounds of team members to be able to take over. So the purpose here is slightly keeping the patient warm. Immobilisation where it's needed. This is only for neck. If you've hurt your foot, I'm not interested in your neck. But fractures and the rest of it need to be protected. It's painful for the patient, and packaging them right helps with their pain relief. We need to remember that we might need to have access to the patient for ongoing assessment whilst we're getting them out of there, whether that is checking that a wound's still not bleeding, or you want to check their breathing rate that you've learned how to do, take a pulse to make sure that their condition isn't changing. So there's lots of aids to packaging about keeping people warm, from full blankets, extra jackets, normal cotton blankets. What we're looking for is things that are really well insulating. You see a lot of bubble wrap used by helicopter teams. It works really well. For us, we've got the CAS bag. It's like a really rugged outdoor sleeping bag. This works really well for insulation. For moving the patients, we want to reduce that as much as possible. If you've decided that they need packaging and carrying out of there, then we're going to try and keep them as still as possible. We want to keep them flat if they were flat. That being said, if you get to a patient and they're in a really difficult position, spend 30 seconds optimising your patient. This is drag them out to somewhere flat if it is reasonable to do so. If you're in a ditch at the bottom of a tree, you're not going to do a resuscitation there. Spend 30 seconds to get your patient to a good working platform, do the best that you can at the time, and then go for a really good package afterwards and just write down what you needed to do to move the patient. So we'll talk about scoop stretchers, and we'll demonstrate one again in a minute. So these are for moving the patient, lifting them in as neutral a position as you can. This is for a patient with a suspected spine injury, whether that's the top of your neck or the rest of your spine. If the patient doesn't have a spine injury, there is no need to be using a scoop. They are cold, they are hard, and they're really uncomfortable to lie on for a long amount of time. When you're rolling somebody to get a scoop under them, there's no rolling them right up on their side. It's 15 degrees, or the scoop is only this thick. That's as much as you need to be able to slide one in underneath somebody. Remember, we're talking about minimising movements. We also carry things like vacuum mattresses. We do have one. They're really good insulators. You can carry it vacuumed, which makes it rigid, or unvacuumed, depends what's wrong with the patient. It does provide good support for other broken limbs, and you can use the scoop inside it if you need to carry somebody out, which is quite helpful. Carrying on a scoop alone is really uncomfortable. Vacuum mattresses is really good if you've got mills in place, so you can vacuum form around the shape of their head to keep it as still as possible. Or you can use head blocks at the same time. We're going to demonstrate a MIBS in a minute. For us, this is quite useful. It's really lightweight, it's really easy to get out to people. You can use a scoop in it. It's got drag handles, carry handles. You can get 6 people in around this to carry it. It's a really good piece of kit to be able to use. It's more difficult if you're carrying a rucksack, so you need to think about kit coordination. And if your patient is making a mess and bleeding and being sick everywhere, it's not the end of the world, but it's quite hard to decontaminate it afterwards. In the water team, we've got saviour stretchers. They're sort of technical stretchers, which is really useful. It uses exactly like a MIBS, which is really helpful. You can carry it, drag it, swim it, drown it, anything that you want to do, preferably not drowning a patient on board. It's easy to clean because of what it's made of, rather than a material. It's just slick plastic. So it's quite robust. It's rated for lifting for rope rescue, so we do have one in the team. If you've never seen it, then get yourself along to water training. A basket stretcher. Now, we've had some in the past. We don't currently use one very often. They are really useful, but you either need the patient to be able to get in it themselves, or you've got to be able to scoop them in it. So it's very difficult to manoeuvre people that are injured once they're in it. So if you put somebody in on a scoop and take the scoop away, it's going to be very challenging to get them back out wherever it is at the other end. On the other hand, if you need a helicopter, that's quite useful to have. Longboards, we don't have any. Some services will probably have some because they're old school and they're still lingering around. This is an extrication tool only. We do not tie people down to longboards. It's bad for their skin and their spine. You don't sleep tied rigid to a flat board. It's not actually your neutral position. They do have a benefit, but they're for a skilled extrication from vehicles more than anything else. There's very little reason for us to use one. That being said, if we're at a really big incident with lots of patients and we're helping, you might not have anything else, in which case they work very much like a scoop that can't be split. So they're just a rigid board that you could carry it and move somebody who couldn't do it themselves. Let's go into a skills session.
Right guys, I'm just going to come in and take mills. Okay, I have the head. Okay, so we're going to get Lou packaged into a scoop here. So if we can start with a roll to the patient's left, and we're going to get the scoop in. Okay, get your hands on please. JT, if you could insert the scoop when we're ready.
Yep.
Anybody not ready? Okay, ready, brace, roll. Looks good?
Yep.
Ready, brace, lower. Okay, just swap to the other side, do the same again. Hands on. So it'll just be a small roll. Anybody not ready? Ready, brace, roll. Heads in.
Head secure. Feet secure.
Ready, brace, lower. Thanks guys. Right, maintain mills. We want to get the mids rolled out over here to the patient's left. And we'll then lift the scoop up and slide the mids underneath. Okay, so I'm just going to have to swap mills. We haven't actually got enough people, so I'm just going to temporarily swap mills. So Sean, you're going to take the head.
I have the head.
Okay. JT and I will lift.
Need to get the side.
Okay, we're going to just put you on the other side, Sean. I have the head.
Yes, the head. I have the head.
Okay. JT, are you ready to lift?
Yeah, ready to lift.
Okay, so on my command, be ready, brace, lift. Ready, brace, lift. Is that in Andy?
Yeah.
Ready, brace, lower.
Yeah, we're in.
I'll take the head back.
You have the head.
Have the head. That's it, guys. Right, now if we just want to get all the straps pulled out and check we've got everything there. It's always important that we make sure we expose all the straps before we start packaging to make sure they're not crossed. Andy, if you're on your side, to make sure the tags are out and they match the colour codes. Get the two black straps out for the feet, and we've got one at the head. That's looking good. Okay, so we're packaged from the bottom up, just getting the straps, the patient straps in, so the stone with the green. So you pass them across, JT, to
Yep.
Andy, and we'll just do a nice loose fit initially, and then we'll start tightening from the bottom up. And with the foot flap, which is always the hardest bit of this, we've got to make sure that it goes over the top of Lou's feet. We have one strap going over the top of her toes and one strap going across the heels of her feet. Just as we're doing that as well, we want to make sure we're thinking about the temperature management. All our patients are cold, so Sean, could you possibly just get the blanket in, and we'll introduce that just before we tighten it, so too tight to band in, so we get the blanket in. Loosen up a little bit, just to get that in. Can you help me have that up? Great. Just fold it back and then do this. Get the strap over it, that's it. Push that side, just so that. As you tighten this one up, let's get the patient to take a big breath in. Nice big breath in, Lou. Okay. That's great. We don't want that to be too tight in case it constricts the breathing. Okay, now just cocoon that in and just tighten it up a little bit more from the bottom up. And if you could just help Sean by just cocooning the stretcher into the scoop as he tightens. When you've done down there, JC, I just need the head strap doing as well, please. Yeah. Same thing on the back strap, Lou, just nice deep breath, please. Great, that's looking good. And JC, if you want to bring this one,
Yeah, I'll bring that one to you.
just pass it underneath. Yeah, that's it. We don't need much on the head end because we've got the scoop in, but just need to bring that together to give it structure. That's it. Mind up the way, JC. Let's just go have a, if you could just do a quick top to toe check down, everyone make sure the strap's in place, all the carry handles are exposed properly, and we're happy with it before we proceed to a lift and carry out. So I'm just tidying up all those loose ends. We happy with that, guys? Looks good from here. Yes, all our carry handles out, all our straps are tight, our patient's in place. Complete packaging. Thank you very much.
So let's talk about some medical conditions that we need to be really aware of and you'd be expected to sort of have a bit of surrounding knowledge about in the future. Now, this will be really easy if you already have your check cards, but if not, don't forget to speak to Casper and pick them up from HQ. They are ready to go. So we're going to cover the key ones that you can see here, which is most of your treatment pack. And they'll have a little bit of guide so that should you come across it and feel a bit lost, the idea is you have your check cards in your search and rescue rucksack. Most of you have the larger size. Some people have a slightly smaller size and can just get it out and have a look. So say you find somebody that's unconscious. So card number 1, it's right up there. And you then need to work out whether they're unconscious due to a traumatic injury or whether you can't work it out and this is potentially a medical issue. So trauma is I fell off a tree and medical might be I took an overdose. So if it's trauma, depending on what kind of trauma, if it's trauma to their leg, we're not worried about their spine at all. But if it's trauma to the back, upper body, chest, head, then potentially if they're unresponsive, you want to use a jaw thrust or posture. We'll show you postural drainage in a video. If it's medical, just go for your standard head tilt chin lift. It's really easy to do. Now you can see a grayed out bit here, which would be for the LRFRs to put the next step in. So anyone with airway management should be given oxygen. So really make sure you think about reporting into control and requesting that if it's available. Put everybody in a blanket. I am not concerned with medical patients being kept in the recovery position. If you have them flat on their back, as long as you are adamant that the patient has an open airway and is still breathing, you can leave them where you found them. If for any reason you're, say, a micro team, like the dog teams, just 2 of you, and something happens that means only 1 of you is dealing or you need to step away for some reason, then a recovery position is quite good to temporarily be able to let go of the patient. So these cards work really well, really quick, really prompt, and they have some notes at the bottom, which is really useful. Like, should we ever come across a pregnant casualty who is unresponsive, they must be left on their left side, never on their right. And this is to do with the weight of the baby. You don't need to be fearful of every woman everywhere. This is only applies if the person is obviously pregnant, because it's due to the weight of the baby. So this is your recovery position, really briefly what it looks like. You've done this training before, but we'll come across it again in our practicals in another day. Simple external bleeding. So external bleeding, not catastrophic bleeding, although the card does actually cover both. So on card 3, Now, right at the top, it gives you some possible signs and symptoms. So they might be breathing really fast or panting. That's because they're losing a dangerous amount of blood. Their capillary refill time might increase because they've got less blood going around. They might have quite a rapid pulse. Remember, your danger zone is under 50, over 120. There is a blood pressure measurement in here, which you are not expected to be able to do, but should your LRFR be doing this skill, remember you have the same check cards sometimes, then it's really useful to know what your danger thresholds are. They'll be cold, clammy, pale. If it's bleeding enough, they will look unwell. Keep them warm, handle them gently. So internal bleeding is get them to sit down or lie down if they're comfortable to do that. Remember your PPE, have a look at the wound. The last thing you want to do is put pressure over something and deeply embed a wound. That being said, if you find a wound with something in it, like a stick going through and into their arm or a bit of glass, please leave it there. Do not ever remove something embedded in a wound. Apply some trauma dressings. If there's something embedded, you need to work around that to leave that sticking out. And then look at applying a second bandage if the bleeding keeps going. Try not to remove the first one because that first clot is going to be one of the strongest ones that we get. For life-threatening bleed, it's apply that immediate direct pressure, and for limb bleeds, if it's really critical and hosing, we're going to think about using a tourniquet, and we'll show you a video about how to deal with this. Internal bleeding is challenging. There's very little that you could do about it, but you might notice things. This is why we're enforcing the fact that you should have a look in your breathing assessment or in your top to toe assessment of bruising, discoloration, swelling, redness, any signs of injuries. An abdomen that's not soft and squishy, so a hard abdomen, is a sign of internal bleeding. So there's 4 possible key areas that you can lose a life force of blood in the body, and this is inside the chest where your lungs can feel, your abdomen, the pelvis, or a significant limb fracture like your upper thigh. Try and lie the casualty down. I'm not worried about them being on a severe head down position, give them a headache, but it's useful to consider it's possible. Raise their feet if you can. This is just a general treatment of shock of putting the blood where it's supposed to be, which is in the brain and the internal organs. Other than that, keep them warm and reassure the patient, and call for some help. Again, closed fractures or crush injuries. Now, crush is quite different, which is a bit interesting. There's just a little note for what's going on. So let's do closed fractures is really easy. Remove any watches, jewelry, anything tight around the limb. If you have a fracture, the limb is broken and therefore it will bleed on the inside, which means it will swell. So don't let anything constrict it. See how much pain they're in. Ask for LRFR to bring out some gas and air if you've got it, some Entonox. Immobilize fractures using splints. Again, we'll cover this in practicals. And if indicated, you can help your LRFR to apply pelvic splints and things like that. Open fractures, same again, but this time you've got to manage a little bit of bleeding potentially. Don't push bony ends back in. Just try and keep it really clean. This is good bandaging principles here of cover the ends, keep it clean and stop it from bleeding. Limb crush is really difficult, and I doubt that you will be leading on this incident for very long at all. This is an ambulance and potentially a helicopter type of incident. So if they're crushed and they've been there for more than half an hour, you're going to leave them there because they need really critical interventions before we get rid of that. That being said, if you're mechanically trapped under a rock and you just can't get out, that's not the same as in you've been flattened under it. You might have squeezed down a little gap. If you have a barrel fall on you, then you're definitely going to be crushed in that. Thermal burns. Burns is like everything. The difficulty here is our environment, because the best treatment for burns remains 20 minutes of cold moving water. That's it. There are no gels. We no longer carry any burns gels on our bags. You have water and you have just little layers. Don't wrap it around of cling film, and this is just to keep it clean. You can of course pour water over the top of cling film if it needs some more water. This will be the challenge just because of our environment, really. But cooling the burn for 20 minutes is effective within the first 3 hours. So the moment that you can, even if it's that they had say an arm burn and you could get them back to the RV, then of course we would have lots of water available. We could start treatment from there. So it might be that your decision making becomes we need to leave because we can't treat it here. Don't burst blisters, again, in your notes. And if there's clothing stuck to the burn, just leave it in place, don't go tearing it off, but you might have to cut around the clothing. Chemical burns is a difficult issue. Again, it is the same, it's 20 minutes of water. Be really careful about eyes. If one eye is effective, really try not to contaminate the other eye. This is quite a useful card. It's all about unknown illness, and you do need to be able to do the FAST test. That would be really great. For it to be FAST positive, as in they are showing signs of a stroke, they only need to fail one of the tests. So if they have a facial droop, that's it. Don't really worry about their arms or speech, just want to know what it's like, but that's it. They failed at one element, they are having a stroke. You don't need to have a failure point at face and arms and speech. Stroke is a time critical neurological emergency. Again, if you don't know what's going on and you go into card 19 and the patient becomes unconscious, not breathing, then it says flick over to card 1, or conscious breathing, then card 2. Those kind of things, which is really useful. Drowning. This is slightly a bit of cardiac arrest, but there's some specific things here. Just because somebody has had a drowning event doesn't mean that they will be in cardiac arrest. So you can have a fatal and non-fatal drownings. So this is submersion, as in under the water, not immersion, just in the water. If you can get them out of the water, that's great. I mean, the water team has some different tools here. However, any one of you can shout at somebody to swim in this direction. You still need to carry out your primary survey, airway, breathing, circulation, keep them warm, go for a secondary assessment. You really need to watch that they don't deteriorate with their breathing, and keep an eye on them. They obviously need to go to hospital if they've had lots of inhalation, if they're coughing up a lot of water. There wouldn't be an awful lot. It doesn't actually fill your lungs, but that might not be very pleasant for them to be coughing a lot. And just keep an eye on that doesn't deteriorate. Hypothermia. So again, we're good at this. Keep people warm is really important. We cover a lot of this. If your patient's time critical, then you need to sort of incorporate hypothermia management within whatever else it is that you are doing. If they're not time critical, then you can do some better prevention methods to stop them from getting cold and wrap them up properly and have a bit more time to deal with the issue. If they're time critical, then hypothermia is incorporated into the care. It's not a thing on its own.
Okay, just checking for danger. I can't see anything. Hi Sean, I'm Lou.
Hi,
Are you feeling alright?
I'm okay.
Okay, I'm just going to give you a quick once over now that we found you. Make sure there's nothing wrong. Is that alright with you?
Perfect.
Okay, well Sean's talking really fine. I'm not worried about his airway. So there's no catastrophic hemorrhage. There's nothing on the floor at all. I'm going to go into his breathing chest. So I'm just having a feel around his chest. Take a big breath for me, Sean. It feels equal both sides. That's really great. I just checked around the sides as well. And I can't feel any broken bones or anything like that at all. Sean, do you mind if I just look up to your armpits and things like that?
Fine.
I'll just do up the side of your t-shirt. So there's nothing around here, no bleeding or anything like that at all. Let's just come this way. And again, I can't see anything strange. Can I look down the front of your shirt?
Yeah, sure.
Let's just have a little look. There's no bleeding, there's no bruising. I'm not worried. There's no sticking anything out. Lean forward for me, Sean. I'm just going to check your back as well. I can't see anything strange, nothing that concerns me. Okay, just sit back for a minute. Do you mind if I just take your pulse for a second?
Yeah, sure.
Fine. So what I'm actually going to do is find his pulse, which is just down on the thumb. I'm going to do his respiratory rate first. So I got 5 breaths in 15 seconds, so he's got a respiratory rate of 20, and I've got 20 beats in 15 seconds, so a heart rate of 80. So I'm quite happy with all of that. He feels nice and warm, but if we're outside for a long time, I could think about wrapping him up. Sean, you haven't got any headaches, don't feel poorly at all, anything like that? Cool. Can I just do a quick chest check on you for a fast test?
Sure.
Just hold my hands for me. Squeeze my hands. Go on, break my fingers. Squeeze tight. Push me away. Pull me up towards you. Sorry. Push me away from you. Great. Just hold your hands up there. Close your eyes. Just keep them there for me. Fab, that's great. Just relax your arms. Now Sean's already talked, so I know that there's nothing wrong with his speech already. It feels nice and warm, not worried about a temperature. And you haven't got any injuries anywhere?
No.
You're not hurt. Can I just do a quick check?
Yeah, sure.
Cool. I'm just going to have a feel of your head. There's nothing going on here. I've already checked his shoulders, down his arms. Can I feel your tummy?
Yep.
It's all soft. It's not rigid. His legs feel fine. Hasn't hurt anything. And I'm quite happy. Sean, do you think you could walk?
Yes,
Let's
I
get you
can.
out of here.
Yep.
Okay. Hello? There's no danger here. Hello? Can you hear me? Casper? Casper? Can you hear me? Okay, just going to hold this airway open. Check for breathing. Sean, can you come and maintain this airway?
Yeah.
Okay,
I've got control of
he
the
is
airway.
breathing. There's no catastrophic hemorrhage anywhere around him. So we're going to check under his back. There's no blood anywhere. Okay, that airway nice and clear.
It's nice and clear.
Fine, let's do some breathing. There's no mechanism surrounding to say there's a spine problem. So Andy, can you do a respirate while I do this check?
Not a problem.
So I'm just feeling for rise and fall of his chest. Hips nice and equal. I can't feel any broken bones. There's nothing crackling. Okay, so let's just have a look down his shirt. There's no bleeding. There's no bruising. I'm going to check up the sides. And this side. Just need to make sure he's not bleeding up here. Nothing at all. Let's just check. Nothing under his back. No. Nothing this side. Okay, I'm fine. Did you get that respirate?
Yeah, good. Respirate was 20.
20. Okay, I'm quite happy with that for now. So, can you do a pulse check while we're there as well?
Yeah.
He feels quite warm to me, but I'll get a blanket in a second. Once you're done with the pulse check, can you get a blanket for us?
Yeah.
Let's just do a top to toe. There's nothing around his head that I'm worried about. Can't feel any problems in his arms. His tummy's nice and soft. He's not making any pain response, no. And his legs, they all feel intact. I can't work out what the problem is. We need to phone an ambulance, we need to leave. So let's get a MIBS and let's get out of here. Did
Okay.
you get that pulse rate?
Yes.
Let's do a bit on triage. We need to know about triage, and I'll make it really clear. There is a small triage quiz as part of your assessment. So triage isn't too challenging. What we're talking about here is when it's not a single casualty incident. So the number of live patients is greater than the number of medical personnel available to treat them. And this is where you need to make decisions about who is going to be treated first. And the method behind it is that we need to do the most for the most. And sometimes as a consequence of that, patients who are nearing beyond help do not receive help because we don't have the ability to provide that care. And it's useful for deciding which patients we then evacuate as well as treat. So the triage categories are quite simple. They're numbered 1, 2, 3, and 0. So they're also color coordinated traffic light style. So immediate is priority 1, P1 you might hear it as, or T1, priority or triage. We don't mind which you use. And they get a red wristband or marked on them or written on them somewhere. This is the unconscious but breathing. This is the cat hem, that kind of stuff. You then get urgent, who are P2, okay, yellow color band, where they probably have broken limbs and therefore can't get out by themselves, but they could probably wait potentially for an hour or so before receiving their care without it costing them their life. Delayed, P3 was green. Generally, you start an incident like this and say, if you can come towards me, you need to come here and get care. And anyone that moves is a P3. So they are injured, but could probably get themselves somewhere. Now, just because you've got a broken arm does not mean that you can't walk away from a major incident. That's a P3, so they need to get themselves out of there. Dead is a 0 priority. It's given a black wristband. It's very unusually used. But dead is dead. If you have an unresponsive person with an open airway who is not breathing, they are dead and we will not be resuscitating them. And the reason for that is that we simply do not have the people, equipment and facilities to be able to conduct proper resuscitation. So if they are dead on our arrival, they will remain dead during the incident. And then, of course, you have uninjured. If they're not injured, they can go away and not be part of your triage, although you need to be aware of containing the general public. So it runs a bit like this. Starting on the top left, you have they got a catastrophic hemorrhage? If they have, put a tourniquet on them, slap them with a P1 red band, and walk away. That's it, they've been triaged. If they haven't got a cat hem, okay, move down. Are they injured? Because if they're not, they are this 0 category and they just go to a survival reception centre. You say, go on then, go over there, walk yourself off. If they are injured but they're able to walk, then they become P3. So they are injured but they can walk to a treatment centre. That is, anyone who can walk, come and see me for some care. If they are injured but they cannot walk, are they conscious? Do they have an airway? An open airway, and are they breathing? So this is a very simple head tilt, chin lift. If at this point of unconscious, open airway, not breathing, they are dead, and we will mark them as so. If they are unconscious, but they do have an open airway and they are breathing, put them in the recovery position. They are P1. Slap band them with a red band. If they are injured, not walking, but they are conscious, then you need to take their respiratory rate. If their respiratory rate is below 10 or above 30, they become a priority 1. There's something going on the inside or on the outside, you might be able to see, that is a critical priority and will need treatment, else they will rapidly deteriorate. If their respiratory rate is between 10 to 29, then that's fine, we're happy. We move on to assessing circulation. And there's 2 ways, either take their cap refill or you take their pulse. So if they have a heart rate that is above 120 or a cap refill that is slower than 2 seconds, they become a priority 1. Equally, if their heart rate, and bear in mind they're breathing, they're conscious, if the heart rate's less than 120, they are injured and they can't get themselves out of there. We do care, but not care quite as much, and they're a priority 2. You will have a copy of this during your quiz, and you will give some scenarios and you will have to triage those patient scenarios as to your treatment priorities. That's what will be expected of you, but you will be given a copy of this to be able to make your decisions. Triage tags look really different. This is the version that my service use, and you just fold it over so that when you put it in the packet the right way up, it shows which priority this patient is, and then you strap that to the patient in somehow around their wrist if they have one. And it gives you the ability to be able to fill in the background of this card, write down any treatment that you gave and sign it, any medicines, any airway, any what did you find when you assessed them. Bearing in mind the first contact of triage is you do the least possible. The first round of tagging is just about priority marking and saving life. It is apply a tourniquet, open an airway, put them in recovery. We don't do any other treatment on the first real triage. This is coming back to it on the second sweeping team who starts dealing with those injuries and removing them. Alternatives, let's be honest, we can be a bit creative here. Glow sticks work really well at night time for identifying where people might be. And again, of course, use the appropriate colours. You can Sharpie on people. Generally, we don't go multicoloured. You're just going to write on them in black Sharpie. And you just say P1, P2, whatever it is. These slap bands work really well. We also carry these in our service, which can be quite useful. I think the only thing that the concern can be is that patients who are slightly more well realise that those who are unwell are being evacuated first, and theft of tags is an issue, but obviously really rare. You can use tape as well. Retriage. Triage is a dynamic process. So the first people go through, sweep a whole, whatever it is, field, train for all of the casualties they can find and mark them, and hopefully try and count the total number of casualties as you go. With the second sweep, some patients may improve or deteriorate on scene, during transport, during extrication, and we may be part of that. So just because they were a P2 when they were first triaged, you still need to reassess to make sure that they haven't deteriorated and now actually are a priority 1. Equally, over triage is a problem. People thinking that things are worse. Really stick to the rules when triaging. This is the only way that we can achieve the most for the most with mass casualty incidents.